Welcome to section 2 of neuropathology. In this section, we'll be discussing cerebrovascular diseases. Let's get started. Here's our overview slide. Let's begin by discussing global hypoperfusion. This is a general term used to describe an overall lack of oxygen delivery to the brain. It can be caused by low perfusion, such as in the case of atherosclerosis or shock, and it can also be caused by chronic hypoxia or repeated episodes of hypoglycemia. Mild or brief episodes of hypoperfusion may only lead to brief confusion, while severe cases can cause widespread necrosis and leave patients in a vegetative state. The most high-yield aspect of this disorder is related to moderate cases of global hypoperfusion. Patients with globally reduced cerebral perfusion are primarily affected in the so-called watershed areas of the brain. These are the vulnerable border zones between the tissues supplied by the anterior, posterior, and middle cerebral arteries. One effective analogy that has helped me understand this concept is that watershed areas are like the parts of a lawn that are watered by overlapping sprinklers. With a normal sprinkler system, the water covers the lawn very well with some overlap between two sprinkler heads like this. However, if the water pressure falls between these sprinklers, then this part of the lawn doesn't get any water and dies. In the same way, the cortex of the brain is supplied by the anterior, middle, and posterior arteries. In global hypoperfusion, there are wedge-shaped areas, as shown in this diagram, that don't get perfused. Symptoms of a watershed stroke are not necessarily uniform, but they're classically described by man-in-a-barrel syndrome, as patients find that they have weakness in their proximal arm muscles, but can still walk and use their facial muscles. The other important points related to global hypoperfusion have to do with vulnerable areas. First, the pyramidal neurons of the cerebral cortex are particularly vulnerable to global hypoperfusion, and hypoperfusion in these areas typically leads to laminar necrosis. Second, in normal patients, the hippocampus, specifically the CA1 pyramidal neurons of the hippocampus, are particularly vulnerable to hypoperfusion events due to their high metabolic demand. Therefore, patients with moderate global hypoperfusion might find that their memories are disproportionately affected due to hippocampal infarction. Finally, another portion of the brain particularly affected is the cerebellum, specifically the Purkinje layer, which plays an important role in integrating sensory perception with motor control. This can lead to some motor difficulty in patients experiencing moderate global hypoperfusion. All right, now that we've covered some of the information, let's review with a quick question. A 74-year-old man with hypertension, coronary artery disease, and obesity presents to the emergency department with 30 minutes of a severe crushing pressure in his chest. His blood pressure is 70/40 millimeters of mercury, and he is immediately given vasopressor medications, which causes his blood pressure to normalize. After his condition stabilizes, he is found to have some significant neurologic deficits. What aspects of cognition are most likely to have been affected in this patient? The patient had crushing pressure in his chest, which is suggestive of acute coronary syndrome, and he also had a very low blood pressure, 70/40. Following the event, he's found to have some significant neurologic deficits. Collectively, these clues should have made you think about cardiogenic shock. And although his condition was promptly treated, he likely experienced global cerebral hypoperfusion and therefore will have sustained some significant damage to his brain as a result. Remember that the areas most likely to be affected by global hypoperfusion include the cerebral cortex, hippocampus, and cerebellum. While damage to the cerebral cortex can cause a number of deficits, hypoperfusion of the hippocampus will likely cause memory deficits, and hypoperfusion of the cerebellum will likely cause difficulty with motor skills and balance. So in terms of cognition, hypoperfusion of the hippocampus will likely cause memory deficits, which is the answer to the question. All right, now let's discuss ischemic stroke. This is defined by insufficient blood flow to the brain to meet metabolic demand. It accounts for 85% of strokes, with hemorrhage accounting for the other 15%. It causes irreversible brain damage in as little as 5 minutes. If ischemia is brief and perfusion is restored quickly, it is known as a transient ischemic attack, or TIA. TIA is defined as a brief, reversible episode of ischemia resulting in focal neurologic dysfunction without acute infarction. The majority resolve in less than 15 minutes. Patients with suspected ischemic strokes with persistent symptoms lasting longer than 15 minutes should first be taken to the CT scanner, and this can help rule out hemorrhagic strokes, which must be emergently operated on. Ischemic changes only appear on CT about 6 hours after onset of symptoms, however. For this reason, a brain MRI is the gold standard for confirming the presence of an ischemic stroke in patients who present with symptoms in the last 6 hours. So an MRI can detect changes within 30 minutes. This is a high-yield table that outlines the pathologic changes that take place in ischemic neural tissue over time. These changes follow roughly the same pattern as inflammatory and necrotic changes in other tissues, including neutrophilic infiltration, followed by macrophage activation. However, there are a few important things to remember in neuronal tissue. The first change to take place within 12 to 24 hours is the development of eosinophilic cytoplasm and pycnotic nuclei, causing the neurons to turn red. As permanent cells, neurons are highly susceptible to hypoxia. The red coloration of the neurons is due to pycnosis or degradation of the nucleus and loss of Nissl bodies, which are normally stained blue with H&E staining. This leaves only the degraded proteins which stain red. This is followed by necrosis and neutrophil infiltration, which is consistent with acute inflammation. Then macrophage infiltration occurs, as macrophages are responsible for phagocytosis, and these attempt to clean up the dead cells and tissue debris. After 1 to 2 weeks, a process known as reactive gliosis occurs, coupled with vascular proliferation. This process, while incompletely understood, has both beneficial and detrimental effects, including decreasing inflammation and restoration of the blood-brain barrier, but also the prevention of axon regeneration. After 2 weeks, this process results in the formation of a glial scar. This helps wall off and contain the necrotic tissue from healthy tissue. It's also important to remember that a glial scar forms around a cystic lesion. The cystic lesion occurs as necrotic brain tissue is digested by hydrolytic enzymes, and this is called liquefactive necrosis. The wall of the cyst is formed primarily by astrocytic processes. Recall that astrocytes are a type of glial cells in the central nervous system. Here's a slide from neurons that have undergone cell death. Note the red eosinophilic cytoplasm, for example, right here. There are 3 main types of stroke: thrombotic, embolic, and lacunar. We'll discuss thrombotic first. Thrombotic refers to clot formation at the site of infarction, usually over a ruptured atherosclerotic plaque, which often develops at vessel branch points. It typically affects one specific territory, such as the MCA, the ACA, or the PCA. Thrombotic strokes typically cause a pale infarct at the periphery of the cortex, as the areas distal to the clot have decreased blood flow, causing them to appear paler. Here's an axial MRI of the brain showing a thrombotic stroke in the right middle lobe. Next is embolic stroke. An embolic stroke is caused by a clot from another part of the body obstructing a vessel. It can look the same as a thrombotic stroke on CT or MRI, but importantly, it can affect multiple vascular territories and should be suspected in patients who present with multiple infarctions. Common causes include atrial fibrillation, carotid artery stenosis, patients that have a DVT as well as a patent foraminovalle, and infective endocarditis. The most common source of embolism is the left side of the heart, and the most common affected vessel is the MCA. Finally, a lacunar stroke is caused by hyaline arteriosclerosis of smaller vessels, usually lenticulostriate vessels. This results in small cystic areas of infarction. It's also important to note that the lenticulostriate vessels are deep inside the brain and can cause pure motor symptoms if they affect the internal capsule, or pure sensory symptoms if the infarct affects the thalamus. Here's a diagram of the lenticulostriate vessels in the brain. As you can see, they primarily supply the basal ganglia and thalamus. Here's an image of a lacunar stroke with the characteristic small cysts deep in the brain parenchyma. Treatment for ischemic brain disease involves administering TPA within 3 to 4.5 hours. TPA helps break up the clot and restores blood flow. The guidelines on this time window are still evolving, and there is some evidence to suggest that it could be beneficial to administer TPA up to 12 hours after onset of symptoms. Thrombectomy can also be considered for larger clots. All right, now let's discuss subarachnoid hemorrhage. A subarachnoid hemorrhage is characterized by a bleed deep in the brain in the subarachnoid space. Most frequently, subarachnoid hemorrhages are due to rupture of a saccular or berry aneurysm. Other causes include AV malformations and an anticoagulated state. Saccular aneurysms are circular outpouchings of vessel walls that lack a medial layer. They're commonly seen in the circle of Willis, especially between the anterior communicating artery and ACA. They generally present as a sudden severe headache, classically described as the worst headache of my life. A lumbar puncture shows xanthochromic CSF, and this is because the brain is bleeding and the red blood cells get broken down, leading to the breakdown of bilirubin, which causes yellow discoloration. And the yellow discoloration is termed xanthochromia. Importantly, saccular aneurysms and therefore subarachnoid hemorrhages are associated with a couple of genetic conditions, including autosomal dominant polycystic kidney disease, Marfan syndrome, and Ehlers-Danlos syndrome. One important and high-yield point to know about subarachnoid hemorrhages is that they're associated with a delayed vasospasm risk. Patients often present with a decreased level of consciousness and new focal neurologic deficits several days after the initial onset of symptoms and treatment of the hemorrhage. This is due to release of vasoconstrictive factors from erythrocytes, causing delayed cerebral ischemia. Nimodipine, which is a selective calcium channel blocker, can be used to decrease the risk of vasospasm. Here's a CT scan of a patient with a subarachnoid hemorrhage. As you can see, the bleeding is deep in the cranium. All right, the last topic we'll discuss is intraparenchymal hemorrhage. This is a bleed within the brain parenchyma itself. Similar to a lacunar stroke, this type of hemorrhage tends to affect the lenticulostriate vessels, with the basal ganglia being the most common site of hemorrhage. Similar to subarachnoid hemorrhage, patients often present with severe headache, nausea, vomiting, and eventually coma. It's primarily associated with hypertension, so effective hypertension treatment is helpful in reducing the incidence. Here's a CT scan of an intraparenchymal hemorrhage. Notice the hyperintensity in the center, right here, indicative of bleeding deep within the brain parenchyma. All right, now that we've covered the information, let's review with a question. A 69-year-old male with a past medical history of hypertension presents to the clinic with a 1-hour history of tingling and numbness on the left side of his face, left arm, and left leg. He has no other symptoms, including motor weakness. A CT scan of the patient's brain shows no evidence of hemorrhage. Which of the following is the most likely cause of this patient's symptoms? A. Hyaline arteriosclerosis, B. Embolism, C. Thrombosis, or D. Hypoxia. All right, hopefully from the question stem, you were able to identify this patient's symptoms as a pure sensory stroke, consistent with the lacunar infarct affecting the thalamus. So he doesn't have any motor weakness, just tingling and numbness on the left side of his face, left arm, and left leg. Pure sensory strokes in the thalamus are almost always associated with hyaline arteriosclerosis, which is a consequence of hypertension. So the correct answer is A, hyaline arteriosclerosis. Here's an image of the lenticulostriate vessels again. As you can see, the thalamus is primarily supplied by these vessels. As these smaller vessels become narrowed by arteriosclerosis, the sensory function of the thalamus can be impacted by the decreased blood supply. B is wrong because embolic strokes tend to affect larger arteries, such as the ACA, MCA, or PCA. They can also affect posterior circulation, but it would be extremely uncommon for an embolic stroke to cause pure sensory symptoms. C is wrong because, similar to embolic strokes, thrombotic strokes tend to cause symptoms in large arteries. You would not expect a thrombotic stroke to cause purely sensory symptoms. D is wrong because hypoxia or hypoperfusion tend to cause damage to the watershed regions of the brain, such as the cerebral cortex, hippocampus, or cerebellum. None of these would manifest with purely sensory symptoms. So again, the correct answer is A, hyaline arteriosclerosis. And that concludes this section.